Hello everyone, this is Beth Lubenthal, and we're going to be beginning chapter 2 here, talking about mental health and mental illness. These two concepts are very complicated, and today we're just going to have an introductory kind of discussion about these two concepts, but as we go over the course, we will start to develop, and as we go through clinical, develop a more deeper understanding of the complexity of these terms, mental health and mental illness. So first of all, mental health. A lot of different theorists have talked about mental health and have discussed many things about what makes up a person's mental health. They talk about individual functioning, how we relate to other people. Maslow had his hierarchy of needs, and I want you to look at that on page 15, and that should be a review for you, but to look at that and to understand how self-actualization for him was part of that definition of mental health. At the end of page 15, you'll see that the authors of your book gave a definition of mental health, and this is the one that we're going to be using, but they talk about the successful adaptation to stressors from the internal or the external environment. So you're adapting to stressors. And how do we know you're adapting? Well, we look at that by what are your thoughts, what are your feelings, behaviors, are they age appropriate, and are they congruent with local and cultural norms? That would be their definition of mental health. Now, if we go on and talk about mental illness, we see on page 16 a beginning definition of that, but also that just the idea that coming up with a definition for mental illness, because we have so many cultural elements involved with mental health and mental illness, it can be very difficult to come up with a universal definition that everybody universally agrees upon. But there are some points that we need to discuss about that can help us look at mental illness a little bit better. So first of all, incomprehensibility. This is a big part of mental illness. This concept basically is saying that we can start thinking that a person might have a mental illness if we are not able to understand the motivation behind their behavior. All right, so take a minute and kind of think about that, not being able to understand somebody's reasons or motivations behind something that they're doing. So for instance, if somebody who is washing their hands maybe 5, 10, 15 times a day, or 20 times a day, or spending longer than 2 hours a day washing their hands, even though it's evident, that their hands are very clean, there's nothing that is dirty with their hands, that might be very difficult for us to understand what their motivation is. Okay, so that might start to bring up the idea of this person isn't adapting, there's something maybe wrong with their behavior that we need to look into more. So that's the incomprehensibility. We could talk about other examples, but I'm sure that you can think of some as well. If somebody is cutting on their arm is another example. Maybe not really trying to kill themselves, but doing self-mutilation in their arms or their legs, areas of their body. It may be very hard for us to understand or to comprehend why they would be doing this or what is the motivation behind that. Okay, so that can be one component of trying to understand mental illness. The second part down here, cultural relativity, has to do with social norms related to mental health, and also then looking at deviant behavior. But these social norms would say that everything has to be understood or is conceived inside our own cultural norms. So mental illness, we would have to look at each society's norms, and determine if it's falling outside the norms, which would be deviant behavior, or does it fall inside the norms. If it's inside the norms, then we wouldn't necessarily say that it is, a deviation from mental health. If it falls outside the norms, we might start thinking about mental health issues towards the lines of mental illness. So for example, tattoos and piercings, okay, are those outside the social norms right now? No, they aren't. Actually, as the years have gone by, tattoos, piercings, that sort of thing is very much in with our cultural norms. Now, say 100 years ago, that may very well have fallen outside of the social norms in our culture and may have been labeled deviant behavior. All right, and may have and it may have been difficult to understand the reason why a person would have piercings or would have tattoos, and so that might fall under deviant behavior, and then more looking at mental illness. Okay, but today in our culture, tattoos, piercings, along those types of behaviors, we are able to comprehend why somebody might have tattoos, why they might have piercings, and it does fall within many of our social norms. Okay, another example might be a person who is hearing voices. Okay, that at this point falls outside of our social norms. We don't have that is not something that is accepted in our social norms. We don't understand that, or we can't comprehend what might be going on with that. And so again, that can be labeled deviant behavior or lie outside cultural norms and may make up that part of that mental illness. So we could go on and on with other examples, but I just want you to think about that. There are also, we can think of, if we go into cultures outside of the United States or outside of Western society, there is a group of people from Melanesia, if I'm pronouncing that right. They typically have very paranoid personalities. They have a lot of fears, a lot of suspicions, and that's just kind of their worldview. We would call that a paranoid personality disorder, and probably would label that if they were here, in our Western society, in our Western culture. But in their culture, in their country, in their social norms, that is very common, and that falls within their societal, their cultural norms, and that is not labeled deviant behavior. It's not labeled mental illness. Okay. The next thing I want to talk about related to mental illness is the DSM-5, and the DSM is a diagnostic and statistical manual of the APA, American Psychological Association. And the history of this is that there was a DSM-3, the first DSM in 1980, and what the DSM tried to do is attempt to make mental illness more objective. Okay, and they tried to really classify signs and symptoms, categorize signs and symptoms, and give them labels or diagnostic mental diagnoses, okay, mental illness diagnoses, and they're categorized. And so we currently now are in the DSM-5, and we use that very much to categorize symptoms and to hopefully bring some objectivity to diagnosing. Now, the DSM-5 is not without its critics, and there are some people who, say that it's just an attempt and it's not 100% accurate, and we have to be careful with it, and that, diagnosing people can be very difficult. But hopefully what the DSM is doing is that if everybody, that people that are diagnosing, physicians, psychologists, so forth, who are diagnosing, if they are using this as a framework, then somebody, say in Florida, who is getting diagnosis of schizophrenia would meet the same criteria as somebody in Iowa who is having a diagnosis of schizophrenia. Or if I'm being treated in Iowa for one diagnosis, I can go down to Texas and have that, and the person will understand if I have the diagnosis of schizophrenia from a doctor in Iowa, what that would mean. Okay, so that's the DSM-5. Incidence of mental disorder we're going to talk about later. The history of contemporary developments, I just want to briefly talk about this, but in the 1990s, which seems like a long time ago, but it is when we had what many people will call the biological revolution. This was a huge change, or a huge increase in the understanding of the brain. Scientists were able to research was just exploding on the brain and how we are able to understand it. how neurotransmitters of the brain and how hormones in the brain worked, how they controlled behavior, how how all of that worked together. And because of this huge, understanding of the brain and research and making sense of neurotransmitters, hormones, etc., the psychiatry has moved from a psychodynamic model, more psychologically based, to more of a biomedical model in psychiatry. So psychiatry today, all right, is more of a medical model or biomedical model. And the last thing I wanted to talk about with mental illness is stigma. And you should be talking about stigma in various courses. But for our purposes right now, I just want us to understand that there's a covert stigma that we may not be aware of, stigma that we are holding biases against people. In mental illness, there are huge biases that many people are aware that they have them, and many people are not aware that they have them. But this is part of something we need to start talking about. Overt stigma, especially by people in healthcare, such as nurses or doctors, or anybody in the public. If we have this stigma towards people with mental illness, it really can hurt and impede their recovery process. Because basically what it does is it prevents those individuals who have a stigma from getting adequate care. Because if I have a bias, if I have a if I have a bias against working with people, or have bias with understanding of people with mental illness, I may not give them the same health care that somebody who doesn't have a mental illness. And we will know, and believe me, oftentimes we think that people in mental who are we practice psychiatric nursing, but we see psychiatric patients whether we're a psychiatric nurse or not. We're going to have, if you're a med-surg nurse, if you're a pediatric nurse, any type of nurse practitioner, you're going to be coming across people with mental health disorders, mental health dysfunctions. Okay, and so we need to be looking at, do we have a stigma, and is that stigma preventing me from giving that person adequate care? Okay, so a good example of that, it would be if an overt stigma, such as I may believe that anybody who has a diagnosis of schizophrenia or any type of mental illness is a scary person and is a very dangerous person. If I have that belief, or if I hold that stigma, I may not be giving that person adequate health care. Okay. All right, moving on to our next slide, psychological adaptation to stress. There are two primary psychological responses, anxiety and grief. So these are two patterns or response patterns to stress. Okay, on page 17 in your book, there's a good definition. Anxiety is a vague apprehension associated with feeling of uncertainty or helplessness. And anxiety really is a universal human feeling that we all encounter multiple times during the day. We may not all encounter panic levels of anxiety every day, but we all will be having mild and moderate types of anxiety throughout every day. Let's talk about this a little bit. I want you to go down and look at your chart that I have on your outline. And your chart talks about perceptual field, and it also then looks at levels of anxiety. And if you also look on page 18, table 2.1, that talks about levels of anxiety, they also will discuss perceptual field. This chart, I think, just puts it in a really clear way to understand that table, and I really like this. And I would, if I were you, I would commit this diagram down here in your notes to memory. This will help you with understanding this concept of anxiety. But you can see that perceptual field is along one axis, and then anxiety is on the bottom axis there. And you can see that a person's perceptual field with mild anxiety, perceptual field increases slightly, and then in moderate anxiety, the perceptual field declines a little bit. And you can see then how severely the perceptual field is narrowed or declines in severe anxiety. And then in panic, there's hardly any perceptual field at all. It becomes very chaotic. So what does this all mean if we kind of look at examples? Perceptual field, if you had to define that, what is that? Your perceptions, your ability to take in stimuli, your ability to take in what's going on in your environment, your senses, okay, your seeing, your hearing, touch, and comprehending that. So in mild anxiety, our perceptual field increases a little bit. We are actually taking more aware of what's going on in our environment, maybe really glomming on and taking in everything around us. Okay, our perceptual field is opening. I like to think of the example of, say, the athlete before the game starts or before a big play is going to start, that their anxiety increases a little bit. But what does that make? That makes them more aware of what twitches that might be going on in their component, what's going on, around them, so that they can respond quicker. All right. Another example of mild anxiety might be the nurse who gets report, say at coming on shift at 3 o'clock, and she gets report that the person, Mr. Jones, down in room 3, his blood pressure has just increased and he's becoming somewhat diaphoretic. Okay, so that makes her anxiety, the nurse's anxiety increase a little bit. But what is that going to do when that nurse goes in and assesses that patient? Because of that increased anxiety, they're going to be able to take in more information, be more aware of what's going on with the patient, taking in more of the assessment. Okay, so that's kind of an example of mild anxiety. Moderate anxiety, as you can see, that near the perceptual field narrows somewhat. So what's going on here? What's going on here? An example of this might be the student who has a big test tomorrow, but yet the other people in their dorm are really noisy, either outside the hallway or next door playing their music really loud. But because they have the stress of a test tomorrow, they are able to shut out some of that perceptual field. So maybe they are able to shut out some of that noise, shut out some of that stimuli that's coming in, so that they can really focus on what's going on in front of them. Okay, and learn that information. So it's important to know that in mild and moderate anxiety, we are still able to learn. We are still able to function and still able to learn. Another example with this moderate anxiety might be the nurse who all of a sudden their patient codes. The nurse calls a code, and if anybody has been in a code, the code team will come, and everybody in the room usually will have some kind of a assignment. Maybe one person will be doing chest compressions, another person might be administering medications, another person might be the recorder. So different jobs, and even though that's a very high stress environment, okay, say the nurse who is supposed to be recording what's happening and taking orders and that kind of stuff, he or she is able to shut out maybe all of the extra noise of the family, or the extra noise of the people doing the chest compressions, or other things that might be going on, and they are able to focus on recording, and taking notes, charting what's happening, and still be able to function. Okay. So then we get to severe anxiety. That severe anxiety is the person's perceptual field becomes very, very, very narrowed, greatly diminished. Sometimes they aren't even able to take in information. They're focusing on a single detail that might not have any relevance to their situation. They may not be able to notice an event even when they're directed towards that. Many times if they are given instructions, well, why don't you move, or why don't you come over here by me, they are unable to follow those instructions. They may not even be able to take in that stimuli of somebody telling them to do something. Okay, so that very severe anxiety. They have unable to concentrate or problem solve. Effective learning cannot hear during the severe anxiety, and many times their behaviors are dysfunctional. And then a panic anxiety, they're unable to focus at all, even on one detail. Misperception of the environment are very common. Learning cannot occur. They're unable to concentrate, unable to comprehend, unable to function properly. All right. So I want you to know these levels of anxiety. I want you to know what's happening in the perceptual field related to these levels of anxiety, and want you to know that table 2.1 related to levels of anxiety. Let's move on to the next. This is signs and symptoms of anxiety. Now, I have these listed down here, but if you would also look at your Table 2.1, it also talks about physical characteristics that are going on, but just kind of all combining all of those, not necessarily related to levels, but I'm dividing, your book doesn't necessarily do this, but dividing anxiety symptoms into physiological symptoms, cognitive symptoms, and emotional or behavioral symptoms. And it's important for us to be able to distinguish between, what are the physiological things that are going on, what's going on in the person's thinking, and emotional and behavioral. And so I have those listed down there. I'm not going to read all of those to you, but you maybe see test questions that give you certain symptoms and will ask you, are these cognitive symptoms, or are these physiological symptoms, or are they emotional symptoms? So I want you to be able to distinguish physiological versus cognitive versus emotional and behavioral. The next thing I want to talk about is defense mechanisms. Okay, defense mechanisms occur in general when a person is experiencing moderate stress. They're used when there's a threat to either the biological or the psychological wellness of a person. Now, I want to talk about the difference between task-oriented responses and defense-oriented responses. Okay, task-oriented responses are task-oriented responses to stress are responses that help us to function, help us to solve the problem, help us to get the job done. They're very much problem-oriented. They deal with the stress, and if you want to say in a healthy manner, but deal with the stress and try to resolve it. So for example, if you have a lot of stress because you have a test coming up, what are some task-oriented ways that you could deal with that stress? Well, you could talk to your roommate or your teacher about the stress that you're having, or just talk about it a little bit, venting. Okay, so that could be a task-oriented response. Studying is very much a task-oriented response. You're dealing with the issue of the test tomorrow, you're learning the material, and you're preparing yourself. Another task-oriented response might be going out for a run or exercising. That's dealing with stress, trying to relieve some of the physiological symptoms that a person might be having stress. It could also just help with the psychological responses of stress. Okay, so those are all task-oriented responses, very much problem-solving and healthy. Now, defense-oriented responses, those are responses that do not necessarily solve the problem. Okay, and I have some of these bullet points on your notes that talk about this. Defense mechanisms are mental mechanisms used to decrease feelings of anxiety and prevent pain. So it's the defense mechanisms are trying to help us. Okay, they're trying to solve the problem. Okay, they're mental mechanisms, mental things that happen, and they're trying to help us out. They're trying to decrease the feelings of anxiety. They're trying to prevent pain. And it actually allows protection for the self. So it does protect us sometimes from anxiety or from pain. Okay? Defense mechanisms most times are automatic, unconscious. They may be inflexible coping patterns. But defense mechanisms start to become maladaptive when they start to interfere with relationships, when they start to interfere with the way we do our job, how we deal with reality. Defense mechanisms can't interfere with rational decision making. So the defense mechanisms, they keep a lid on the anxiety. They prevent us from feeling anxiety, but it really doesn't solve the problem, and it prevents growth. Okay, so whereas task-oriented responses really aim and deal with reality, try to solve the problem, defense-oriented responses protects us prevents anxiety, but it does not prevent growth, and it many times does not solve the problem in a healthy way. And if continued long term, can start to become dysfunctional. There are some examples where defense-oriented responses might be healthy in a short-term manner. For example, the defense mechanism of denial. If say I just heard that my son was killed in a car accident, my first automatic unconscious kind of coping pattern might be denial. Oh no, that can't happen. He wasn't driving today, or I might just be in denial for a period of maybe a few minutes, or it might be for a couple hours, just so until I am able to comprehend that material and understand and cope with it, and that sort of thing. So sometimes in the very short term, denial can be healthy, but if a person had denial for a long period of time, that would be considered unhealthy. So the defense mechanisms, I want you to know all the definitions and all the examples that are listed here on your notes, on your outline notes, and those are all listed in your book. Okay, now, so I'm going to let you take notes on those and you understand those, and then we will be doing some exercises and reviewing of those in class. Okay, now grief. Grief, we are just going to start to take a look at this. This is actually a level 4 concept. However, the HESI NCLEX will have questions on grief. So grief is a subjective, emotional, physical, and social response to the loss of something that is valued. Okay, that's just a real kind of short, to the point definition of grief. Something that has to have something that of value that has been lost. Okay, and the grief is either the physical, emotional, or social response to that. Any situation that creates change can be identified as a loss. Okay, so granted, there is value in it, but also something that creates change. So it might not be just that you lose a loved one, say in a car accident, but it might be something that creates a change, such as you move to a new city to go to school. Okay, so maybe you have lost the dynamics of living with your family and being around your hometown, and now you're in a new situation. But grief can be experienced because there's some of that loss of being with your own family. Okay, so that's just one example. Failure can also be seen as a loss. So just be aware of that. Somebody who might fail fail out of school, or somebody who fails a some other type of important test, that can also be seen as a loss. Okay, stages on page 20 and 21. I want you to know the stages of grief, Kubler-Ross. Want you to know those stages of grief. Those should be a review for you, so I'm not going to go through all of those. Anticipatory grief, I'll just continue on. Anticipatory grief, I want you to know what that is. That is grief before a person actually loses something. Okay, so it only becomes a problem if, say, you go through premature or anticipatory grief and you start to withdraw from the situation or withdraw from, say, a dying person. That can then prevent you from giving support to that dying person. So I kind of got ahead of myself, but for example, anticipatory grief. You might be aware that somebody that you love has cancer and they have, say, 6 or 8 months to live, and you start to go through that grief process. Many times, maybe more insular, but you go through that grief process, that anticipatory grief of them dying, and maybe you have resolved the fact that they are going to die, and you have moved through all of those phases. And because of that, you start to withdraw from that dying person and almost feel that that person has already died. Now, if you do that, you withdraw from the dying person, you may be withholding support to that dying person, withholding, unconsciously withholding love and that sort of thing. So that's the only real reason that anticipatory grieving might become a problem. Resolution of grief can take from weeks to years. And everybody goes through grief and goes through those stages individually. Factors that might lengthen grief can be guilt, if you have excessive guilt surrounding that relationship. If there is a love-hate type of relationship, that can also lengthen the resolution. If a person has many recent losses or many losses happening at once, that can lengthen that stage. Sometimes we call that bereavement overload. So, and that oftentimes happens with elderly people and likely can cause that person to go into depression. But many times elderly people may experience the death of a spouse, death of many friends. Maybe they're experiencing moving into a nursing home. So there's a lot of loss and a lot of grief that's going on in their life. That can become bereavement overload and might move that person into depression. If a person is not able to complete a grieving process, many times it starts to become maladaptive. And then it may be that resolution cannot be achieved. And if resolution cannot be achieved, or if it's very maladaptive, or if it becomes prolonged or delayed, distorted, that person might start to move towards other types of maladaptive coping, such as drinking, carelessness, not taking care of themselves, moving into depression. Okay, so I want you to understand that area of your book that talks about the stages of grief, anticipatory grieving, and resolution. And the last thing I want to talk about on this slide here is the continuum of mental health to mental illness. We call it a continuum because there are not any, many times there's not stark black and white lines that say, yes, I'm mentally healthy or I am mentally ill, okay, but that a person is able to move back and forth on this continuum. So for example, if a person is, say, diagnosed with schizophrenia, they may be closer down on that continuum of mental illness, especially if they are having their first psychotic break, where they might not be in touch with reality, might be having hearing voices, not able to take care of themselves, are in the hospital. But as they maybe are treated, start some medications, start to become stabilized, they may be able to move home with a loved one or significant other. They may be moving towards recovery and understanding their illness, and might be able to get a part-time job, may be able to go back to their full-time job, being stabilized on their medications and that sort of thing. So they might actually start to move up into the middle of that continuum, and if stabilized, has resources, support, may actually move into recovery and go up on that continuum up into mental health. So you can see where the a person can move back and forth on that mental health, mental illness continuum. Another example might be, say, a student who is in finals week. All right, or before finals week, let's say, they're high on that, somewhere around that mental health area on the continuum, and maybe they're getting into finals week and have 4 or 5 really big high stakes finals, and they're studying a lot. Maybe they're not getting very much sleep, maybe they aren't eating very well, and they start to have a lot of anxiety symptoms. Okay, and maybe they are having some crying spells. Maybe they are having some difficulties concentrating now, and maybe they are starting to move down a little bit on this mental health continuum. All right, and again, so they're wavering, maybe more in the middle of this, or maybe a little bit down. There, might be a student who is unable to complete finals because of, extreme anxiety or panic or that sort of thing. So, I mean, that would be very, very rare and wouldn't, happen hardly ever, but it might make them move down to different areas of on this continuum. So just some examples there that I want you to think about, and to know that we are all, whether we have a mental health diagnosis or not, we are all moving up and down on this mental health, mental illness continuum.